about trunk nerve blocks. I'm not going to take a lot of time talking about this topic. I'm just going to talk a little bit about intercostal and transversus abdominis block. The superficial cervical and the paravertebral nerve block, I recommend you to read them. Now, the intercostal nerve block is of advantage for thoracic surgery, abdominal surgery, breast surgery, rib fracture, herpes zoster, or cancer of such an area. Okay, the bad news about the intercostal nerve block that it's associated with highest blood level absorptions among the blocks. So the local anesthetic toxicity, because of the presence of the nerve and the artery, and the blood supply is most prominent with the intercostal nerve block. And that's also the reason behind the short duration of the intercostal nerve block. Sometimes the paravertebral nerve block, the posterior approach, has replaced intercostal nerve block for many procedures. Okay, pneumothorax is another complication for intercostal nerve block. Now let's talk a little bit about the anatomy of the intercostal nerve block. You know all that the intercostal nerve arises from the dorsal and the ventral rami of the thoracic spinal nerves. They actually exit from the spine at the intervertebral foramen and enter a groove on the underlying side of the corresponding rib. Okay? The important thing to know is that the nerve running with the intercostal artery and vein. Okay? Nerve is generally the most inferior structure in the neurovascular bundle. Okay? So as you can see here, it is the most inferior. This is the rib. This is the vein, artery, and the nerve, the most inferior. Here, from here to there, is the superior to inferior. So it is the most inferior structure. Is the most inferior structure. Sensation is from the dorsal, the midline dorsally to the midline ventrally. Okay. How to do it? Actually, it's an easy block. You put the patient in lateral decubitus or supine position. Lateral decubitus is preferred. You palpate the level of each rib in the mid and posterior axillary line. The mid and posterior axillary line. You palpate it and you insert a needle in the inferior edge of each selected rib. Okay, so this is a rib on the inferior edge of each selected rib until you feel the bone. Okay, when you contact the bone, the needle is then walked off inferior slightly. Okay, you walk off inferiorly. The needle is then redirected slightly cephalad, and you advance it just about 0.25 centimeter, and you aspirate and you give 3 to 5 millimeters. So again, this is the rib on the inferior wall of the rib. You contact the bone of the rib, then you slide it on the edge of the rib, and then minimal cephalic direction 3 to 5 millimeter to accomplish intercostal nerve block. Now let's move to the other block, which is the transversus abdominal plane block. Let's just watch this video on how to do it, the intercostal nerve block with ultrasound guidance. This is the pleura, and this is I have no pointer. What is it? Okay. You can see the rib, pleura, and the rib. You advance the needle, you can see the needle below the rib, just inferior to it, with minimal cephalic redirection. Give your local anesthetic, and by this you accomplish your nerve block. Again, pleura, and rib in the inferior wall of the rib. You give the local anesthetic, and as you can see here, the pleura depressed my last topic for this lecture is the transversus abdominis plane block, the TAB block. The TAB block indication is for minor superficial procedures of lower abdominal wall. So the deep procedures of lower abdominal wall will not work with transversus abdominis plane block. Okay, and sometimes for post-operative analgesia below the umbilicus. But for just for hernia repair, for example, you can't rely on transversus abdominis plane block alone. You have to give IV drugs or another type of blocks. The complications of transversus abdominis blocks, the specific complications, the possible violation of the peritoneum or the perforation of bowel. And that's why the use of ultrasound is of benefit in this block. When you do a transversus abdominis plane block, you block the subcostal, the iliohypogastric, ilioinguinal nerve, and the block target is between the internal oblique and transversus abdominis muscles. That's why it's called the transversus abdominis plane block. Okay, because you block between the abdominal internal oblique and the transversus abdominis plane. You can do it with supine or lateral position. Lateral is preferred, but if the patient can't tolerate the lateral position, you can do it with supine position. This video will show you how to do the transversus abdominis plane block, and this will be our last video.
Transducer with a nerve exam type is used to perform an ultrasound-guided ilioinguinal and iliohypogastric nerve block. The target depth is approximately 3 centimeters in an 80-kilogram adult. The patient is positioned in a supine position. The transducer is placed over the bony prominence of the anterior superior iliac spine with the orientation marker directed to the patient's right. The transducer is rotated slightly counterclockwise, so one side rests on the anterior superior iliac spine and the other side points at the umbilicus. The medial side of the transducer is slowly swept superiorly and inferiorly while maintaining the bony iliac crest in the lateral part of the ultrasound image. The structures of the anterior abdominal wall should be identified from superficial to deep, including adipose tissue, external oblique muscle, internal oblique muscle, and the transversus abdominis muscle. A fourth muscle, the iliacus, may occasionally be visualized underneath the transversus abdominis. The nerves are located between the internal oblique and the transversus abdominis muscle layers. They may appear only as hyperechoic thickness between these two muscles or as dark hypoechoic oval structures with a bright hyperechoic covering. The nerves are very closely related to the iliac crest. The needle is advanced using an in-plane or out-of-plane technique. If using an in-plane technique, centimeters medial to the transducer and advanced under the transducer. The end point for the needle is between internal oblique and transversus abdominis. The local anesthetic is injected incrementally close to the nerves.
Okay, thank you very much.